So welcome everybody. It's very exciting actually to have a room full of people because as a gerontological nurse I have many a times presented to an empty room. So it's very nice that you're all here, and we have our people who are joining us virtually as well. And for those of you who are in the room, the catering has not quite arrived yet, which is Murphy's Law of my life. But at least I'm here and it's 8 o'clock in the morning. So I'm Jennifer Baumbusch. I'm very happy to be here. I'm an associate professor here at the UBC School of Nursing. And I was very excited to be asked to give this nursing rounds, given where we are in the state of the country and where I am sort of in my thinking about what I do as a gerontological nurse. So I'm going to be throwing out that term, and for anybody who's unfamiliar with it, a gerontological nurse is someone who specializes in the nursing care of older adults. So that is what I would consider my specialty area. And I always kind of like to start with a little bit of a story. So when I agreed to give this talk, it was sort of pushed me to look across the work that I've done. And in fact, it was 20 years ago, right now, that I was sitting in this room as an undergraduate student here at UBC, looking forward to my final Avenues class in January and my preceptorship. And at that time, we didn't offer a gerontological nursing Avenues course. And so I finagled for myself to do the mental health class with Janet Erickson, who some of you may know, and went on to do my preceptorship at the stat unit at St. Vincent. And so I look at that, and these were the books I was reading because I was a geek. And, you know, I was soaking it all up, and at that point, you know, we were talking about needing to get ready for our aging population. And these are today's headlines. So the aging population is going to strain Canada's healthcare services. Our hospitals are not ready for the Grey Tsunami. And the headlines really haven't changed. And so for 20 years, I've been hearing people talk about we need to be getting ready, we need to be getting ready. And when I look at where we're at, our headlines haven't changed. And when I go and teach, and Lynn Essen's here today, in every term lately, I have been teaching a session in her class of older adult nursing, and I always give my little soapbox talk about gerontological nursing and invite people to come up and talk to me, and I talk to people about the area of nursing they're interested in going into. And without fail, there's about 40, 45 people in the class. At the end of the class, maybe one person will come up to me, and I kind of check over both shoulders to make sure nobody's there. And they say, I'm reading into the microphone, I think I might like to work with older people. Like it's a dirty secret. And that's really distressing for me because it kind of is very telling about how far we've come in nursing around recognizing and claiming our pivotal role in working with this population. So this is the brief outline of my presentation. It's pretty straightforward. Here we are. I'm going to provide some exemplars from my program of research. My research program is mainly, I would describe it as, and I've written it down, applied qualitative clinical research in health services aimed at improving access and quality of care for seniors. And really the focus of this talk is about nursing's role. I realize there's a lot of things driving in today on the early edition. On CBC, I had the pleasure of listening to their panel talk about seniors care, and the real focus is on pharmacare. And we have great experts here at UBC like Steve Morgan to talk about those things. That is not what I'm talking about today. So I just want to put that out there so nobody feels terribly disappointed when I don't start to talk about it. And so I'm going to give these examples and then talk about where do we want to be, because I think it's too late to be talking about where we're going. We need to really be thinking about what strategies can we put in place now. So I'm going to talk briefly about the aging population, and this is no surprise to most of you because we hear it in the news almost every day. Currently, nearly 1 in 6 Canadians are over the age of 65. The population for healthcare that is almost more of needing attention are those who are over the age of 80. So when you look at the box where it shows seniors age 80 and over, we can see that increasing to almost 9.6% by 2045. So when we look at the two little pillars there we see this very quickly moving now. We have sort of been having this slow demographic shift, but now it's going to come as a really big push for us. So we need to be really thinking about what we're doing now, not what we're doing later. So now I wanted to talk about, where do we see seniors in the actual healthcare system? So this is a quote from a workshop that I did just a year or so ago, where someone said, if you just went up to somebody and said, tell me about geriatric nursing, I think most people would say, well, that's long-term care, that's residential. I think that's where geriatrics live. But where do geriatrics live? So this is the first myth we really need to debunk. So seniors represent currently 14% of the population and utilize 45% of all public sector health spending, 40% of acute hospital stays, 44% of emergency room visits, 82% of home care, and 95% of residential care. Geriatrics does not just live in nursing homes. Where do nurses live and work? 60% of nurses work in hospitals where 40% of their patients are older adults. 18,000 emergency room nurses work in hospitals in Canada. Do they know what their specialized gerontological nursing knowledge is about those 44% of patients we're presenting who are older adults? What's happening with our geriatric emergency nurse roles in our healthcare system? And where we look at who we consider to be the true specialists in this area, it's just 10% of nurses, 25,000 nurses who work in residential care. And I will put this out right now, residential care is my home, so I consider that my area of practice. But I think we really need to think about these messages that we sort of soak in and think, this is where geriatrics lives, and if I'm working in the ICU, I don't identify as being providing nursing care to an older adult, even though the average age of ICU patients is over 60. That's concerning because there is a whole specialized body of knowledge that goes along with caring for this population. The other piece I wanted to touch on before getting into my research is seniors as providers of care. Millions of Canadians are providing hundreds of millions of hours of caregiving to older adults. They are some of our main partners in care as nurses. And we need to recognize this because the number of hours that are provided by informal family caregivers is going to continue to rise sharply over the next few decades. And in particular, a place where we haven't fully explored what that role looks like is acute care within our hospitals. Within our hospitals, some of which still have very restrictive visiting hours. And so those older adults who might have advanced dementia, who are there because they broke their hip and might be experiencing a delirium and are really, really afraid, don't have access to their main familiar caregiver, except for 2 hours a day when they might be allowed to visit. So this is a huge area that we're not even really touching on yet, is what does caregiving, informal caregiving look like in our hospitals? And in other areas, we have a clearer vision of it, but I'm not sure we always see those informal caregivers as members of our interprofessional team. So that is where I see seniors as receiving and providing care and where they're really interacting with nurses. But there's another big thing that we need to really consider in this conversation. So the three pillars I kind of see and observe in my research and when I travel out in the world with clinical colleagues is that we have silos. We have the aging population, we have nursing, and we have healthcare reform and restructuring. And they exist most of the time fairly independently of each other. And that if we think of it even as a quilt, where we should be weaving these things together, and sometimes we claim that we do, if you're a quilter, you know that if you make a mistake on a panel and it causes a little pull, everything else gets pulled and nothing looks very nice. And that's what happens a lot of the time. So we're not really doing a very effective job of weaving these three pillars together in a really intentional and thoughtful way. So when I think about what I see in my research and looking at things, it's more something that looks like this. We have seniors care in the middle, we have the aging population informing seniors care, and we have healthcare reform and restructuring informing seniors care. Oftentimes, those don't intermix together in a very thoughtful way. We have nursing. Nurses are the largest workforce in Canada in healthcare, providing the foundation and platform for the system but we don't often see nursing really integrated into how we're shaping the delivery of seniors care. We're there, we're on the receiving end of decisions that are made and how the system's going to work, and we're actually providing the care, but I'm not sure that we're often very well integrated into how that planning happens. And I will talk about this all in my talk. So I'm going to shift into some of the research exemplars, and they really focus on the health reforms and the impact on older adults to really show how those top bubbles are sort of informing seniors' care at this point in time. So my research really happens across the continuum of care, and I have the wonderful opportunity to do research in hospitals, community, and residential care. So one of the most interesting partnerships I have right now in research is around innovations in cardiac care. So I have to say that as a long-term care nurse, I got pulled into a point of care research challenge, which is a wonderful program for point of care nurses to come up with their own research ideas. And I was pulled into a team by a great group of nurses, and once we started to look at some of the data and I started to read the transcripts, I said, like, how old are these people that are these patients that you're talking about? And they said, well, they're all in their 80s. And I said, well, you're doing my work. And we could see that there was this siloed effect of even cardiology and geriatrics, where we didn't get together because we're both working with the same population. We got together because I had a particular research skill set that worked with this group. But now, over time, we've developed a really great partnership and are weaving in different specialties. So when we look at the health reforms that have affected this area, we have innovations in care. So now people who historically might have had open heart surgery can come in, have a minimally invasive procedure done, awake, in the procedure room, and go home the next day. And these people are in their 80s and 90s. So I'll just say here, go home the next day when we know that delirium actually manifests itself after 2 to 2.5 days. What happens there? Centralization of care. This also makes sense. We don't have a lot of people that can provide this procedure, so obviously it's going to happen at provincially coordinated centers. And then we have the decreased length of stay, which I've already mentioned. So none of these are bad things, and that's what I want to point out. When we look at the things happening in health reform and restructuring, they make sense, but we don't necessarily put it together with the other pieces that it's pushing on. So then we look at the impact on older adults, and we know these older adults in particular have advanced cardiac disease. They have increased frailty and complexity of care, and many are living on a fixed income and limited social support. So those are the two things coming together in this piece of seniors care. So this is the study that we've done that was funded by CIHR, and it was to examine the complex medical, functional, and social needs of community-dwelling older adults accessing this innovative cardiovascular intervention at a provincial cardiac center. We conducted a focused ethnography, and we've been doing this study since the summer of 2013. So I want you to imagine this patient's journey. And I have to give props to anybody who can drive to downtown Vancouver, find parking, pay for parking, navigate the inside of a hospital that is basically a bunch of dissimilar buildings fit together with elevators that can take 10 minutes to arrive, and do this in their mid-80s, because I often run into problems when I'm trying to do it. So this is what it looks like. You get referred to the program. You go for an initial assessment visit at the provincial site. Then, if you live locally, you'll go back for a pre-admission clinic visit, and then you'll go back when it's time for the procedure. So those are 3 visits to the site. If you live at a distance to the center, oftentimes the pre-admission clinic visit and the actual procedure will be partnered together so that you don't have to make 3 visits, you just make 2. So this is what we did as we followed patients. We interviewed them at the time of referral. You know, why are you interested in doing this? What do you see as an outcome of having this procedure? We observed interactions in one of the clinics. We then interviewed them after the clinic visit. Did you get the information you needed? Did you get to ask the questions you wanted to? Then we went when they had the procedure, and we observed what happened in the critical care unit afterwards. And then we interviewed them at 2 weeks after they had the procedure, and then at 2 months after the procedure. because this is such a new procedure, there aren't a lot of clinical guidelines to associate with them yet. And in fact, the experiences of patients haven't really been explored when they go through this. And you see the drop in numbers because we recruited a total of 31 people into the study, and then those who were eligible for the procedure, there were 15. We then look at those 15, and we're always curious about what is it like for someone who lives close, which we call in town, within 100 kilometers, and those who live out of town, those who live more than 100 kilometers. Recognizing that they may live in an urban center somewhere else in the province, but they still, you know, if you're coming from Prince George, you're still flying down. If you're coming from Victoria, you're still taking a ferry or flying or doing whatever in this province that we have. So I'm not going to go through all of the demographics, but you can see that the average age was 81 and 82 for the people who lived in town and had the procedure. So this is a map of who participated. And I think in British Columbia, sometimes we forget how large this province is, and that for some countries in the world, we could fit several of them into our province. So down where you see the cluster, that is where the provincial center is. The participants who actually had the procedure are the red stars, and those who didn't are the yellow stars. So you can see we even had someone from way up in Fort Nelson who did not have the procedure. So again, thinking about that person in their 80s coming from Fort Nelson to the pre-assessment clinic and the complexities. And you know what? They have to figure that one out on their own. It's not, we've arranged. It is, your appointment is on at, see you then. So these are the 15 participants that actually had the procedure. We had, as I said, 7 in town and 8 out of town, and this shows the gender of the participants. And then what we did, because we cannot stop them, we have their informal caregivers participate in the research. In the very first study we did with this group, we had informal caregivers that we could not stop from participating in the interview, even when we let them know that they weren't actual participants in the research. So since then, we have always included them, and this is what they look like. So kind of a gendered situation here, and I wish I could have done 10 talks on this topic, as you could tell, and one of them could have just probably been on these few slides. But this is what the group looked like when they came. So about half had extra support, and I would say that when you see that these are men with their wives, they had the most support, I would say. And it was funny because sometimes the patient would get on the phone for an interview and they'd be like, okay, well, I'm done. And the informal caregiver wife would stay on the phone for quite a bit longer to tell, you know, their perspective on the story. Very interesting. So one of the things that we wanted to look at with this group is what are your out-of-pocket costs? So this is something that we tracked with this group of 15. And what we found was for those people who lived within the 100 kilometers of the procedure site, they spent about $100. For those people who lived out of town, they spent about $900. So that's a huge difference for people. And when we look at income across sort of urban and rural areas, we know that the likelihood of those people who are spending the $900 having more financial assets than those who live close to the center are unlikely. So this is a huge strain and can actually be a decision-making factor in whether or not you go forward to have this life-saving procedure. So again, we looked at this as a sort of in-town and out-of-town and the mediating factor around costs. And I'm not going to read every quote all the way through, but what was really interesting was this bottom quote where it was someone who lived close to the center but was kind of thinking this through as if she didn't and lived further away. And she said, and I think they would wonder if they even want to go through with the procedure. Ought that be a reason for an older adult not to have a procedure in British Columbia because of the cost? And we do have some programs and policies that can assist with those costs, but then we need a system for ensuring people are aware of that. And even with those systems, it's not going to eliminate the cost differential for this group. The other thing that we looked at is access to informal support. And I think this is a really important quote Because sometimes we assume because there's a lot of people around an individual that they have a lot of support. And again, we have to look at each patient that is a senior, not only as a receiver, but as a provider of care. And so this participant said, after I read the aftercare and all that kind of thing, and I honestly have to say this, I don't know who I would call to help me with the aftercare. I couldn't ask my son to be taking time off work or his wife, both of whom would do it. My older daughter, who can't stand the sight of blood, couldn't begin to do that. And my younger, especially after that accident that injured her back, I wouldn't ask her. So she's identifying 4 potential caregivers there, but she declined to go further along the assessment process because she didn't want to ask any of them for assistance. So this is another reason why someone may not proceed with the procedure because of a mitigating factor. This is another sort of interesting one that we're just starting to explore and is leading into the next newest part of this research program. So I'm trying to present today that everything needs to be considered as a whole. I'm not trying to impose values of good or bad on things. But when we have older adults who are in their 80s and 90s coming in for a procedure, I think, part of the question is, what do you expect? And are those realistic expectations? So this is her caregiver explaining, what she wants to get out, and she's really excited about, and this was post-procedure, I think, and she's not doing it blah, 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 but she has no plans of climbing Mount Everest. And the patient says, yeah, not today. And what we're finding as we continue to do research with this population, and we're now doing a 1-year follow-up study with them, is because of the complexity of seniors, this procedure fixes one issue. It doesn't fix the diabetes. It doesn't fix, the COPD. It does not really fix the heart failure in the long term. It doesn't fix all those other things. So the next part of the research program that we're going to be hopefully looking at is, what does it look like when you are providing this kind of care using a palliative approach? And for those of you who know a palliative approach, it's not palliative care, but it's having conversations early on. It is okay to make the choice to proceed with this procedure if that is the right thing. It is okay to not proceed. But what does it look in the larger context of your life, within the larger context of your health and well-being, and what your goals are as an 85-year-old? And so I think nursing has a critical role in being able to have those kinds of conversations, because we are usually spending the most time with patients. So that was my research exemplar about seniors as receivers of care. This is about seniors as providers of care. So this is my other area of research, which is more in long-term care. So this is long-term care nursing homes, long-term care facilities, whichever term you like to use. So when we look at the health reforms that have really impacted on this sector, about 15 years ago, a little less than 15 years ago, when I was still a director of care, we had a shift from levels of care. So those of you who know the old system of categorizing people from intermediate care to extended care, and we had purpose-built facilities for people who are intermediate care and those who are extended care, we moved to a system of complex care that said, well, here you go. And the reality is that most people who are complex care are extended care. That happened without funding to change those purpose-built buildings that had no ceiling lifts or any kind of lifts, and have sometimes small doorways that have exits that aren't alarmed for people who might be wandering. That had a huge impact on the sector. So we went from having this really diverse mix of levels of need and care to having only complex care. And we also saw staffing composition changes. And so we saw a shift from having registered nurses to having LPNs provide the majority of nursing care on site. We also had a shift where staff of a site could be contracted to another employer. So when you walk into your typical care facility these days, rather than being able to talk to people who think of themselves as being part of the same team, and when, Manager Jennifer used to sit there, everybody was on my team, everybody reported to me, you might be in the course of an hour or two visit talking to people who have 2 to 3 to 4 different employers. As much as people might not think that has an impact on the culture of care, it does. So how does this impact on seniors providing care? So in the literature about family members of people who live in facilities, it used to really look at those family members as providing socio-emotional support. But what we've seen is a shift to those family members providing much more hands-on care, actually doing morning care, evening care, helping people at mealtime, all of the types of hands-on care that we can imagine. We also see family members and residents supplementing the staff with paid companions. This is a hugely invisible workforce in care facilities, so much so that there's really no research at all about them. And these are individuals who, when I used to be a nurse on the floor, it would be sometimes somebody from the church would be coming as a regular volunteer or as a paid companion to sit with that family member who is living in a care facility. But now these staff are coming in and doing the A to Z of care. And care facilities are actually becoming reliant on the paid companion staffing contingent in order to provide basic care, even though these individuals are not employed by the facility and have their own arrangements with the families or residents they might work for. And the other thing that's emerging in my research now with families is that you're seeing this shift in role, and they're feeling very much adrift, not having the support or education to really understand, like, how do I do these things? And I'm going to provide some examples of what families are now doing. So this is the study that is ongoing right now. It's called Inviting Dialogue on Experiences of Active Involvement in Long-Term Care, Perspectives of Residents and Families and Staff, really around the negotiation of care in these settings. So these are the objectives of the study, and I'll just sort of, won't go through each one, but it's really looking at how families currently involved, how are they currently involved in care work, and how is that negotiated. This is an overview of the study and the different phases. We are just finishing all of our data collection and local knowledge translation at Site A, and we will be moving into Site B and Site C over the next year. So for the data collection we've done so far, we've done interviews with 19 participants, 11 of whom are family members, and we've done 41 observations, which is about 83 hours of observation. And so those observations obviously include a larger contingent of participants than just the people who are participating in the interviews. So this is an observation narrative, and I think, you know, this is a really piece that reflects sort of those dynamics that occur in a care facility. So I will just read this one out. It's a little bit small. So in the field notes, the research assistant writes, on the way back to resident's room, a female care aide stops the husband and says, I forgot to put the hip protectors on today. And the husband replies, hip protectors? She doesn't wear hip protectors. And the care aide explains, they started doing a trial. She's been wearing them now. Nobody told me, he said. The resident continues to roll down the hall without the family member of the observer, and the care aide just says, talk to the nurse. This is a family member, by the way, who visits every day. So the family member runs his hand through his hair, and the care aide sort of shifts her weight from one foot to the other and says, Dr. 2 decided that she was at high risk of falls and we're doing a trial. Dr. 2, I thought Dr. 3 was only doctor, he said, before it was decided that hip protectors were unnecessary, but if you really think it's necessary, and the care aide adds, it's only a trial for 2 to 3 days. And she goes and gets more care aides, and they go down and they shut the door and they start to put the hip protectors on the resident. And so the research assistant says, so hip protectors were unnecessary before? And the family member says they were. That his wife's only issues with balance when she gets tired, and she's a wheelchair for that. And he adds that they've tried hip protectors before, that they give her a rash. And they didn't consult you or the resident's doctor before doing a trial with hip protectors now? And he says, no. I could photocopy this, put it on every resident's bedside table, and have a family member say, yeah, something like that's happened to me. Is it really that difficult to connect with someone who is there every single day to let them know about the hip protector trial? And I get that this maybe seems like a small thing, but it is a wearing down of this family caregiver, a progressive wearing down, where he is coming every day to connect with his spouse of many, many decades, trying to feel like they still have some control over what's happening, and yet that isn't evident in what's happening. And again, you see a care aide who is not empowered to explain the situation and says, well, you need to talk to the nurse. Well, where is the nurse? Is the nurse filling out her MDS-RI forms, or is the nurse off with another resident? I get, and again, I'm not trying to position anybody as good or bad. I get the complexity of what happens, but this is just sort of a typical interaction. So we wonder why things blow up. We wonder why people get frustrated. We wonder why we have to spend a lot of time in fixing relationships between residents and family members and staff. But this is a great example of what happens there. The other thing we heard a lot from families that is new and that I haven't seen in literature before is around their role in negotiating safety. So when we think about that complex resident population of people with typically advancing dementias who used to, when I would be working, be in the special care unit. Well, the parameters around who goes in the special care unit is quite different now compared to when I was working. Everybody's together. So these, again, are family members that are typically on site quite a bit. And they're seeing themselves as witnesses and mediators. So one said, I've been refereeing combatants up there sometimes because I'm the only warm body standing up. And I've had to separate or do something because people were going at each other when there was no aide there. And it's not that the aides are not there. They might all be in rooms providing care, but we don't have enough aides in order to have somebody who's circulating in the common areas all the time. Another family member said, you learn as you go and you learn who's dangerous, physically dangerous. These are people going into their vulnerable family member's home every day. Another said, and then I don't know how to call downstairs to get somebody to come and help, to go down and get an aide. Sometimes people have fallen and there's nobody. I'm not supposed to lift them, but I can try and stay there until somebody comes so they don't bang their head on the floor trying to get up if they haven't. It's happened several times, and there are some very worrisome acting out people. So again, the family's sense of, how am I educated to deal with this? Because I'm not just here visiting my family member. I know everything about everybody who lives here, and I am managing this. And I'm not unhappy about that situation, but I need some support to be able to do it. So I'm never suggesting that we should require families to be involved, but you know what? There are lots of families who want to be involved, who want more information about what does it mean to have dementia, what does it mean to be aggressive or have responsive behaviors. So we need to think about how can we be proactive and provide those tools for this group who is here all the time and who, quite frankly, our frontline staff really depend on in order to get through the day. So I return back to my original piece. Those are my examples around the aging population and health reform and restructuring impacting on seniors' care. And you can see, I hope, that nursing provides the foundation for this, and nurses have critical roles in all of this. So I'm going to turn now a bit to how are we preparing nurses for this role. So this is just a general slide about levels of education of nurses in Canada, and we don't know what these numbers mean in relation to seniors' care. When I did a study about 15 years ago looking at the state of gerontological nursing education across Canada, schools reported that about 5% of nursing students were reporting that they had an interest in working with this population as they entered their nursing careers. 5%. And yet we know this is not 5% of the patient, resident, client population. So what are we doing about it? So this is a study that I did with TLEF funds a few years ago. So within our school, we have integrated adult and older adult nursing into the same courses. So we looked at, well, within this context, do nursing students actually learn anything about the older adult population? And can it have an effect on their perceptions around caring for this population? And we were really pleased to see improvements between the beginning and the end of the course. But this was the first course they took in their program, and it raises questions of how do we sustain this throughout their program and beyond, so that when people are getting to the point of choosing their preceptorships, it's not 5%, it is 50%, because I think that should be the goal. 50% of people want to work with older adults, because at least that many, that's where they will be working. The group that is often ignored in research are clinical instructors. This is a key group. Research shows that clinical instructors have a huge impact on nursing students' beliefs and values about the patients they look after. How do we support our clinical instructors to be passionate about nursing care of older adults? So we did, as part of the TLEF, we also explored clinical instructors' perceptions and knowledge about nursing care of older adults. What I will say is these clinical instructors have responsibility for students who are in this mixed course, and when we looked at their knowledge and perceptions and compared them to nurse educators who work on geriatric floors or who self-identify as geriatric nurse educators, the nurse educators had significantly better knowledge and perceptions about nursing care of older adults than the clinical instructors. So this is concerning, because if the clinical instructors are not our rock star cheerleaders of older adult nursing, everything I say in the classroom is kind of for naught. So one of them said to us, systems and the model of care and care delivery are not what the students are hearing in class. Surprise, surprise. Trying to instill a gerontological nursing focus, that's a huge challenge. So how are we supporting this group to make those connections between what happens in class and what happens in clinical, and how are we supporting their knowledge and beliefs about older adults? The other area I want to talk about is continuing education, because again, we have a huge contingent of nurses out there right now who are working who have not perhaps received any education about nursing care of older adults in their pre-licensure program, depending where they did it. And those who did may not have even thought about it since they graduated. So Maureen Shaw, who is a now retired clinical nurse specialist, and I developed the Geriatric Education and Training Program with funding from the Michael Smith Foundation, and we delivered this. And the program is really centered around person-centered care, family-centered care, the nursing process, and evidence-informed practice. And what we did was we had one day where we talked about foundations in nursing care of older adults. We then had a day when we talked about the consequences of hospitalization for older adults. We then talked about how, as nurses, do we meet these challenges? How do we get to a place where we feel empowered? The neatest thing we did in this project was have the nurses get into groups and develop QI projects where they went to their units and identified what they thought could be fixed. And two of my favorite projects that came back were very gerontological nursing focused was ensuring that mouth care happens, having a little mouth care package that goes with each patient, making sure that it gets done, and making sure that people's glasses and hearing aids are in. This is not highly advanced stuff. Both of those things will help prevent deliriums. So it was a fabulous project. When we looked at changes in their knowledge and beliefs, we didn't see changes in knowledge. I'm going to blame that on the tool that we used. But what we did see, which was really interesting, was between the end of the program and 3 months afterwards, we saw improvements in their beliefs about nursing care of older adults. So I think that this is a place that we really need to have focus, and where organizations can show leadership around focusing those professional development opportunities around this area. This curriculum is available through open access on UBC Circle. We encourage anyone to pick it up. We are happy to talk to anyone about customizing it. And we're hoping to be working in the next year with a rural hospital in the interior to adapt it for their needs, and to also expand it beyond registered nurses so that their interprofessional teams can work together in it. The last area I wanted to touch on is seniors care and nursing practice. We have done some nice charts to make those numbers make most sense. So this is across Canada, percentage of RNs and LPNs by work areas. So across Canada, you know, in hospitals and long-term care, things have remained pretty stable. We have seen a bit of a drop of RNs in the community and a bit of an increase in LPNs in the community. I put this up because we often hear a lot of rhetoric about what's happening in the hospitals, and I think sometimes we need to look at the numbers. So the numbers in British Columbia are different than the national numbers. So when we look at the RNs in hospital, this has bounced around a bit, but have increased overall, while LPNs have actually decreased between 2008 and 2012. In the community, RNs have also bounced around and LPNs have increased. Where we really see a difference is in care facilities, where we see that RNs have gone from 10% to 7% of the nurses in this sector, and LPNs have gone from 36% to 43%. So in the hospitals, when I go and take my traveling show around, one of the concerns people talk a lot about is, all the people from long-term care who are coming into emergency unnecessarily. So let's think about that in the context of who's providing care and the supports for those individuals providing care there. And when they make that decision to call 911 for somebody who is in a care facility. So I think it's really important that we have that as an understanding of what is happening to the RN workforce in British Columbia. We also, in our GET program, talk to nurses about what are the factors that influence your readiness to care for hospitalized older adults. And I'm ending with this bit of research because I think this comes from the nurses and this is really critical. So uncharted territory. You're caring for people who are living longer than ever before, and so it's uncharted territory with lots of them. If I don't know how to look after this population, I can't look after them adequately. So how do we address that? Why is it uncharted territory? Why are nurses looking at somebody who's 90 coming to them from the ICU as uncharted territory? And how do we support that? The influence of the organizational context. Physical environment. This is something that nurses talk about a lot. Because guess what? Nurses go into life with their eyes wide open. So when you build a beautiful new tower and it is gorgeous and has windows all the way around, and you say, but we're going to leave geriatrics in the old building, and we'll retrofit it for you over the next decade or two. People get that. Like, there's a valuing there. There's a valuing about this population. When every new piece of equipment you get is a hand-me-down from another unit, there is a valuing there about what is the value of this population. When my patient ratio is different and higher than the person working on the young adult unit, there is a valuing there, and people see it and they get it. So they talk a lot about this resource disparity that they see in their organizations between what the younger adults get and what the older adults get. The staffing mix, and this goes beyond nurses. So if you have a complex patient population of people who have dementia, delirium, and all the other wonderful things that come, you need to have some recreation therapists. You need to have some rehabilitation assistants who can mobilize people, because we know that loss of function is one of the most detrimental things that can happen to older adults, and the likelihood of them going home after hospitalization when they have lost function is nil. So if we have staff there who can get people up and get them moving, that is really key. And organizational priorities. I feel like we are more focused on patient flow than patient care. So beliefs about nursing care of older adults. Professional esteem is a huge concept, I think, in this area that crosses everything I've talked about. And people said, I don't think there's a lot of respect for nurses that care for the geriatric population. So why would I want to go work there? Why would I want to go lead there? Why would I want to go do that when I could go work somewhere that is a much higher professional esteem area? Another participant said, we have preconceived notions about what it is to be old, and I think we come with that baggage as nurses and healthcare professionals. And I don't doubt this, and it was funny because when I first started doing the slides, that first slide around the numbers said older adults are 14% of the patients, yet they use. And I changed that to and, because I think in every word we use, we have to question, why are we using these words? Does it matter that, or is it not obvious that this aging population is going to use a larger portion of the healthcare system? I don't think that should be surprising. I think I should be happy that as someone who is not considered an older adult, I'm not in the hospital all the time. So I think we need to question the way that we talk about things as a blame of this population, and that the nurses, you know, who look after this population are somehow a second class within our nursing family. So I'm getting towards the end. What is nursing's potential role? So I titled this talk, Nursing's Pivotal Role, because I truly think it can go either way. We can either have a role in making seniors care excellent, or we can have a role in making seniors care not that great. So it's up to us as a collective to decide which way are we going to go. So I think that I present this as some challenges to my nursing community. So in education, I challenge educators to promote gerontological nursing as a valued specialty. From where I stand, I firmly believe that every nursing school should have a required standalone gerontological nursing course, period. That's it. And in fact, every health profession program should. Because when we look across the health professions, nursing is not that different a lot of the time from other health profession programs. And I think employers really need to promote professional development and continuing education in this area. So when we look at CCRS, we need to think about where are nurses being able to get this content. In practice, I think the challenge is to transform the disengagement of nurses to engagement. And I think that is perhaps the greatest challenge, because over and over and over again, they've been disappointed. And so I think looking at the excitement that we felt around having point-of-care quality improvement projects was wonderful. That was the most inspiring takeaway from doing our GET program. The other piece of work I haven't talked about that Sherry Dahlke recently published about was reciprocal practice in nursing care teams. So when she's done research in teams that mixed RNs and LPNs and care aides, you know, the RNs will say, well, I go do that for them, but they don't do anything for me. I feel like I'm doing it all for everybody. So what does reciprocity look like? And when we implement a program like collaborative practice, there is no end date on the education and support that those staff need. And so how do we continue to support these teams to provide excellent care and understand their roles and how their roles interact with each other? I think the challenge for leadership is to always put on our nursing hats. When we look at what's happened across our healthcare system and what's happening in our seniors, how many nurses were at that table and did they say, I'm a nurse? This is what I think we need to do. And I will even go so far as to say, I don't think there's much left to lean in this system. I think we have leaned all we can. We need to be smarter about what we're doing, and we really need to be thoughtful about what we're doing. Because I believe that if we can do that, and I have worked in some fantastic places, and I have, you know, worked at the gold standard. Why do we have gold standards in some places and not in others, but when we have the same budget? Where do our values place what we're actually funding across education and practice? I think as nurses, we need to self-identify, because some nurses get to sit, and I'm sure they do, and I'm not saying this to, you know, put anybody in a corner, but I think we really need to think, what would nursing do? The last one is around policy, and this is where I think the challenge is to be unified. So in the past year in British Columbia, we've seen a lot of division across our nursing groups. Among other things, what this allows everybody else to do is sit back and say, oh, let those nurses fight amongst themselves. And we get absolutely nothing accomplished. So I think the challenge for all of us is to be unified in how we present ourselves as nursing within the healthcare system. Because again, nursing is the largest workforce in our healthcare system. So I would say as my concluding thought, my second to last thought, is that rather than be worried about the tsunami of older people in our healthcare system, we should be thinking about the tsunami of nursing and what we could collectively accomplish if we actually work together to do that. And I think that is where the pivotal piece comes in. If we could be unified, if we could work across all levels from the point of care up until the highest leadership with the same push, we could transform seniors' care fairly rapidly. So my last slide, that last slide, by the way, was my grandma and my dog, is a slide I often end on because this requires a philosophical shift. So perhaps the greatest challenge posed by an aging population is to create a society that values interdependence as well as independence, that acknowledges vulnerability and invalidity as part of all human life, and in which self-respect no longer rests on personal control. And shifting our thinking philosophically as nurses, I think, is the place to begin in order to start this transformation of seniors' care. So I just want to acknowledge all of the research participants across these many studies. The research unit team, Tamara is here today, and Jenny has been part of the team, which is awesome, and Jay Young, and I can't look across the whole room, sorry. But really, this is not one person standing here. This is work that is done by many, our community partners and our funders. So thank you very much.